Great. All right. So maybe I'll just begin. Yeah.
Yeah.
Great. So hello, everyone. It's so great to see you all here. And as we begin today's event, let's take a moment to remind ourselves and, of course, to remember that we are on the unceded land, guardian people of your nation, and acknowledging this fact is quite a vital step towards, of course, anti-colonial and also social justice practices within an academic system, which we are living in and practicing. And by reflecting on and actively engaging with these practices, let's hope to contribute to meaningful politically and also legally structural changes in our own practices, and also to make sure we positively impact Indigenous people, faculty, staff, and students. So today's event, I'm so happy to have here with all of us, Professor Justin Oakley. And this is our first event in the series of Sydney Health Ethics Conversation Series. And we are thrilled and honored to have here Justin. Just briefly, I'll mention about the works which he does so that we all know. I'm sure he doesn't need introduction himself. So Professor Oakley serves as the Deputy Director of the Monash Bioethics Center at Monash University and has made significant contributions to the field through his extensive publications. And his key works include Morality and the Emotions and Virtue Ethics in Professional Roles, co-authored with Dean Coffey. And his research spans various topics on clinical trials, informed consent, surrogate motherhood, and also and whistleblowing too. And recently, he has turned his attention, at least when having brief conversations with him, on the nuances of shame in post-retirement phase. And that's very interesting and exciting, and I'm curious to hear more in future on that. So today's session, Professor Oakley will share on developing a virtue ethics approach to moral responsibility and blameworthiness in professional role failures. So floor is yours, Justin. And the format is 30 minutes. Justin will share with us his presentation, and we'll have rest 30 minutes to unpack and question and have more discussion.
That's fantastic. Thanks very much, Supriya, for inviting me up here, and thanks for coming, those of you here in person and also those of you on Zoom. So what I'm going to do in this talk is to put forward what I hope is a distinctive way of understanding moral responsibility and blameworthiness. And this is turning into the last chapter of a book project I've been working on for a while now on policy applications of virtue ethics. And yeah, very keen to hear your thoughts on this and how this goes. You know, often in my work, in the last chapter of a book, for example, I do something a bit more speculative. And that, or, you know, this talk is kind of in that vein as well. So, but I'm particularly interested in examples of individual practitioners. I'm going to take the example of doctors where they fail to, as you might put it, hit the target of the relevant virtue, but they're working in an environment, so to speak, institutional environment or regulatory environment, which is not supportive of doctors hitting that target or being able to hit that target. So I'm going to tell you about an example like that and kind of use that as a bit of a case study for this problem, and then try to illustrate this account that I'm in the process of developing of a sort of virtue ethics approach to moral responsibility and blameworthiness in that context, or in that case as a bit of a case study. So how might we develop a distinctively virtue ethical account of the grounds of an agent's blameworthiness and also moral responsibility? And so what I mean by that is an account that's able to recognise that various agents who fail to do or to meet or act in accordance with what the relevant virtue dictates might have, if you like, differential moral responsibility and therefore differential blameworthiness. Is this something that, you know, virtue ethics can make a distinctive contribution to, given that virtue ethics, I guess, is better known for a theory of right action, sort of providing you with a criterion of right action. And so, interestingly, just in terms of the context of debates about virtue ethics, there's been work probably in the last 15 years, really, going back that far, to try to develop less individualistic forms of virtue ethics. Always been one of the criticisms of virtue ethics. It's kind of doesn't seem to take enough account of the institutional structures that individual, let's say, doctors work in. And so I think a lot of the work that's been done to try to provide, if you like, a more kind of more kind of situated account of what a virtuous doctor would be is to look at both the institutional structures they work within, but also the regulatory structures that doctors work within. And that's kind of what I've been doing as well, is just kind of thinking about what sorts of regulatory structures and institutional structures would be supportive of doctors both developing and acting on the relevant role virtues here. And so it seems that still there are cases where doctors who have virtuous dispositions act wrongly, not from, or perhaps not only from, a lack of insight, but rather because of, or in part because of the absence of these sort of virtue supportive environments that I'm going to talk about. And so in those cases, it isn't entirely clear whether or not the doctor who acts wrongly in those latter circumstances, where there's a lack of institutional support or perhaps regulatory support for doctors acting virtuously, it's not entirely clear whether or not the doctor who fails to hit the target of the relevant virtue in that context should be regarded as equally blameworthy as a doctor who fails to hit the target of the relevant virtue in a case where it's more perhaps down to them in that context. So let me go on to talk about a bit of a case here.
Yeah.
Right. I'm probably spending too long on each slide. So all right. So let's consider an historical example of this kind of case. It's one that I've used in other work, and I think it's helpful for this kind of problem as well. So in 1847, the American Medical Association developed the first national code of medical ethics anywhere. And in that code, amongst other things, they said that the physician should be the minister of hope and comfort to the sick, that by such cordials to the drooping spirit, he may smooth the bed of death, revive expiring life, and counteract the depressing influence of those maladies, which often disturb the tranquility of the most resigned in their last moments. Now, I read that as that doctors should instill hope in dying patients, possibly even if that hope is false hope, sort of ill-founded hope, perhaps. And if you kind of think about the state of medicine at the time, you know, it was sort of in the early days of scientific medicine, and it might be that, you know, it was thought, hey, this is one of the tools of trade that doctors can offer, is to help be supportive and instill hope. And it's a little unclear. There's this sort of big side issue here about, well, okay, hope for what? So we can talk about that if you want. But to me, it at least includes hope of surviving longer than maybe, you know, they've got more time, telling the patient they've got more time than they actually have. But it also might, at that time, include hope for one's soul in the afterlife, if you believe in such a thing. But just take that kind of example and, you know, try to imagine doctors at that time in the US sort of thinking this is the guidance from their professional association, and they've got dying patients. This is one of the things they should be doing to be like a virtuous doctor at that time. Now, these days, if you think of like the role virtue of medical beneficence, it's not anymore standardly understood as involving, in end-of-life kind of settings, a disposition to instill false hope, maybe even hope, although that's, I suppose, more debatable if it's kind of well-founded hope. But in any case, I mean, this is an area where the profession has kind of moved and changed. And I think that in a lot of cases, what was previously maybe understood by the profession as an expression of medical beneficence isn't seen that way anymore. It's seen as sort of unjustifiably paternalistic and not really in patients' best interest, you know, to be deprived of the truth that a lot of them at least would be keen to know about how much time they have left, for example. Nonetheless, you might wonder about the mid-19th century American doctor instilling false hope in their dying patient. It might seem, you know, okay, we're judging them from our perspective now. And you might think that, hey, you know, given that the AMA were telling them to do that sort of thing, such a doctor, evaluated from a virtue ethics perspective, perhaps, or just from any perspective, might be less blameworthy than a doctor who did that, instill, let's say, false hope, without their professional association saying, hey, or, you know, encouraging them to do that kind of thing. should we think that virtue ethics has the resources to accommodate those judgments of diminished blameworthiness of agents who act in circumstances that present countervailing influences to their acting virtuously and rightly? Here you've got the association sort of telling you instill false hope, well, instill hope, and even if it's false, kind of thing. Now, this is not yet getting down to virtue ethics, not quite yet, but you can think of the concept of blameworthiness as consisting of two components. And so you might think that the blameworthiness of the agent for their wrong action can be reduced or removed altogether because actually the action itself wasn't wrong. It might have looked wrong, but then we kind of think about it differently and we change our evaluation and think, no, actually that wasn't wrong at all. But importantly, and the part of this I'm interested in today is there might be grounds for thinking the agent's level of moral responsibility for their action is perhaps diminished or maybe removed altogether. So let's focus on that second ground of diminished blameworthiness. Okay, so I want to investigate the compatibility or otherwise of virtue ethics with a traditional account of moral responsibility. Sorry, you could investigate the compatibility of virtue ethics with a traditional account of moral responsibility. I'm going to try and sort of develop a different account of moral responsibility, as you'll see. But the traditional account is one, or it could be one. I mean, there's lots in philosophy, but this is one, that an agent A is morally responsible for Xing if and only if Xing was under A's control. This is quite controversial, as reasonably avoidable for A, and we can talk about that if you want. But also thinking of holding agents morally responsible for the consequences they bring about, that A is morally responsible for consequences C of Xing if and only if C were reasonably foreseeable consequences of Xing. So I've got reasonably in there, and I've got that, and that's common, but that's the part I suppose I'm wanting us to focus on. That's the part that I'm contrasting the virtue ethics approach I'm trying to develop here with. So I think a distinctively virtue ethics account could go a bit further than just thinking about that traditional account of moral responsibility and seeing how it matches up with a virtue ethics approach to right and wrong action. That wouldn't, in my view, be especially a virtue ethical account of moral responsibility and blameworthiness. So instead I thought, well, okay, let's try to develop a different account by focusing on the concept of avoidability as control. So we can think of this as an account of control, if you don't like avoidability for various reasons to do with Harry Frankfurt style counterexamples, et cetera, et cetera. But I'm going to focus on avoidability and see how far we can push this, but also foreseeability. So explicating those two concepts in terms of what a virtuous agent in the circumstances would be able to avoid and would be able to foresee. Where, and this is a kind of slightly tricky part, where that, what a virtuous agent would be able to avoid, what a virtuous agent would be able to foresee, can differ from what a reasonable agent would be able to avoid and a reasonable agent would foresee, as often interpreted. So I'm thinking there's a conceptual gap here, which I'm hoping to exploit, but, perhaps that remains to be seen. Now, of course, a simple way to maybe close that gap, if that's the right term, is to say, oh, well, hold on a minute, why don't we just understand reasonable or rationality as itself a virtue? That'd be one way of doing it. People like Ralph Wedgwood has a book on that. And so you could say, okay, there isn't any sort of room here to develop something a bit different. But I actually think there still is. And I'm going to try and illustrate that with an example or with a comparison between two doctors in mid-19th century America operating under that first code of ethics and in the context of end-of-life decisions and instilling hope in dying patients. Okay, so it's this comparison that I'm going to be focusing on for the rest of the talk and different ways of understanding it and maybe lessons we can learn from it about moral responsibility and blameworthiness. Okay, so let's take Dr. A and Dr. B, the comparison between them. Both those doctors, let's suppose, act to instill what they realise is false hope in their dying patients. So, they're aware that this is what they're doing. So they're saying to the patients, in other words, oh, you've got like another 3 months to live, when maybe the doctors realise the patient's only got like a few weeks. Okay, so but where Dr. A and Dr. B differ is Dr. A, when they instill false hope in dying patients, they wholeheartedly endorse their doing so. And because they take that to be in the patient's best interests. So I think this is what, the virtue of sort of medical beneficence requires of me. And but Dr. B has some doubts about that, and maybe is onto more contemporary ideas, contemporary to us, about actually it's on the whole not in patients' best interest to be giving them false hope. Nevertheless, Dr. B proceeds to do so because, and somewhat reluctantly, because they're concerned about incurring significant professional opprobrium if they did otherwise, given the code of ethics of the AMA at the time. Okay, so they go ahead, and Dr. B goes ahead and does it anyway. So it seems like both those doctors have acted wrongly by kind of relevant virtue ethics account of right action. Nevertheless, in terms of moral responsibility and blameworthiness, you might think that Dr. B is less blameworthy in what they do than Dr. A. You might think that because Dr. B's level of moral responsibility for their action could be seen as at least marginally somewhat diminished because of how they're responding to what they perceive to be sort of professional, duress almost from the AMA at the time. Not that the AMA going around checking on every single doctor, but they kind of, it's this felt, oh, look, I better do this because maybe my colleagues will even report me to the AMA kind of board of, or, ethics review board or something like that, if they had such a thing in those days. Okay. So what I'm going to try and do is see if any of you have that intuition about Dr. B being less blameworthy than Dr. A in the circumstances. Is this something that, how can we use that as a bit of a test case for developing, both illustrating and developing a distinctively virtue ethics account of moral responsibility and blameworthiness? Well, as I kind of gestured at early on, here's one way it could be done. You could try and do that by spelling out the normative standards involved in terms of what a virtuous person would do and what a virtuous person would foresee here. So here's a way of doing it. Got various pros and cons. So Agent A is morally responsible for action X if and only if A performed X, and a virtuous person would have been able to avoid doing X. So it's something that is not overstraining human nature, as Aristotle put it, to avoid. But in terms of consequences of actions, Agent A is morally responsible for consequences C of action X, if and only if they performed X, a virtuous person would have been able to avoid doing it. And third, a virtuous person would have foreseen C as a consequence of X. Okay, so this approach ties moral responsibility to intellectual virtue about what a virtuous person would foresee and would choose to endure. So you can say, okay, if there's an Aristotelian virtue here, what is it? You might think it's an aspect of practical wisdom, perhaps, and especially those aspects of practical wisdom that Aristotle talks about concerning judgments about what pressures are worth enduring for which goals. Talks about it in book 3 of the Nicomachean Ethics, talks about it in his account of courage as well, and sort of picking your battles. But also when it comes to foresight, those aspects about, or that concern, if you like, meticulously investigating potential risks and benefits of one's actions. So Aristotle doesn't say a lot about this kind of thing in general, but he's got this, I found this quote that kind of illustrates it in book 6, chapter 7. It said, "It is to that which considers well the various matters concerning itself that one ascribes practical wisdom, and it's to this that one will entrust such matters. That is why we say that some, even of the lower animals, have practical wisdom," or Ross translates it as intelligence. You might think it's a stretch to say animals have wisdom, viz. those which are found to have the power of foresight with regards to their own life. So you might think it's that aspect of phronesis in Aristotelian terms. So now getting back to the role of doctors here, this account obviously would explicate the relevant normative standards, moral responsibility and blameworthiness in terms of what a virtuous doctor would have been able to avoid and what a virtuous doctor would foresee. So on that account, both Dr. A and B and Dr. B would be morally responsible and blameworthy for seeking to instill false hope in dying patients at that time, if and only if a virtuous doctor in that context would have realised that this is actually not in patients' best interests and would have been able to resist any concerns about perceived professional opprobrium from the AMA if they were to avoid doing that, seeking to instill false hope. So that's what it, I guess, would amount to. Okay, but a little bit more detail on what this might amount to in practice, because you might think, hang on a minute, theoretically, yeah, maybe that kind of makes sense and sort of fits with some fairly standard principles, if you like, of moral responsibility and blameworthiness, and puts a bit of a twist or a different slant on them. But at the same time, you might think, hey, hang on, this could end up being incredibly demanding. Especially, there's been a lot of criticisms of virtue ethics as setting this very, very like unattainably lofty ideal for right action. Likewise, you might be concerned that this sets an sort of unattainably lofty ideal for avoiding blameworthiness, for sort of not being culpable when one does the wrong thing. And indeed, Kant says, and I've made a lot of this in other work, he says he's doubtful sometimes whether true virtue can really be found anywhere in the world, because he thinks that, all of us at the edges, or in this, if you like, the remote scenarios might find ourselves in, the chips are down, true colours come out, and no one's got, true virtue, according to Kant. That was a bit of a flourish in the groundwork, but it's one that I've had fun discussing. So yeah, look, I mean, as the book by Robert Adams, on virtue and virtue ethics, it sort of emphasizes is that this is obviously this standard for virtue is obviously too demanding, that human moral excellence can't be an ability and readiness to respond well to every possible circumstance. Adams talks about the social dependence of virtue, the environmental dependence of virtue, if you like. So he's got some really interesting and helpful things to say on that. So let's suppose we took all that on board and didn't go with Kant and set the standard a bit lower than that really. We've never seen there's never been a virtuous doctor. Seems to me, nevertheless, a somewhat demanding standard seems especially appropriate here, given that we're looking at the royal virtues of, hey, a doctor, right? Who, has society expects them to sort of face maybe pandemics up to a point, without going so far as reportedly in the early days of the SARS pandemic, some doctors who in Toronto who exhibited what I would regard as a misplaced sort of bravado when it was in the early days, and going in there and saying, hey, I'm still reporting for duty in hospital. Yeah, there's this weird thing, weird sort of infection or, disease coming up, and don't fully understand the risk, but you might be too scared, but sorry to do this, but but I'm going to go in and, help these patients. That's our mission or whatever. I don't want to set the standard that high. And there's kind of interesting discussions, obviously, in the context of the COVID pandemic about doctors doing that and what a virtue ethicist should say about that. So I don't want to set the standard that high. So I'll talk about Dr. House in a moment. Not so much on TV these days, but probably a lot of us would know about Dr. House. And but the reason I want to go on to talk about, to use the example of House, is because I think one of the helpful aspects of this kind of virtue ethics type of approach to moral responsibility and blameworthiness is that it kind of connects that area, that topic, with a lot of ongoing debates right now about the attainability of virtue. And so it's a little bit, it doesn't just set some obvious standard. It's kind of, maybe this is not in the slides, but just to try and sell that to you a bit more as an advantage. In discussions of the law of medical negligence, there's often been, for many, more than 100 years, been discussions about what a reasonable person would be. But I think now, when it comes to what like a virtuous person would be, I think that discussion about where to set the bar kind of thing is a lot more kind of empirically informed than it used to be. And I don't know about reasonable person in the law, but I think that's a good thing. If we can be a bit clearer about that and a bit more sort of evidence-based. Okay, but let's just take House as an example. Like, suppose I'm thinking of him as a sort of virtuous doctor. I mean, he obviously lacks all kinds of other medical virtues, but let's suppose when it comes to this foresight, sort of in the medical context, like he's really good at it. Let's just suppose, for argument's sake, we set the level of practical wisdom for medical foresight at a very demanding standard. Okay, now, given the analysis I mentioned before, this might inculpate doctors for negligence in cases where it seems unjustifiable. Because suppose only a brilliant doctor with the level of clinical acumen and insight displayed by Dr. House would have foreseen that a particular medical procedure would likely harm a certain patient, and he's brilliant at this, right? He's sort of, everyone's going one way with the diagnosis. He comes up with something out of left field and it turns out to be the right one. And I don't know, maybe it's luck sometimes, who knows? But then according to the normative standard that I outlined, other doctors would then be blameworthy and negligent for failing to foresee those harms, if and only if Dr. House would have foreseen them, using his skillful insight, perhaps. But if most doctors aren't able to inculcate House's level of clinical acumen, it might seem unjustifiable to hold them blameworthy and negligent for failing to foresee what only someone like Dr. House could foresee, given that he's really quite exceptional. And so maybe then, if you think there's something to that thought or that concern, maybe we should be trying to set the bar a bit lower than Dr. House for what counts as the level of foresight you need to have if you're going to be able to escape being held culpable when things go wrong. So, so it might be getting back to doctors A and B. That would seem to set a suitable level of standards of moral responsibility and blameworthiness for the mid-19th century American Dr. B instilling false hope, because this doctor wouldn't be fully blameworthy for such actions, given that there is some maybe risk of professional opprobrium, but for failing to do it. And yet B would still remain somewhat blameworthy for it, given that they recognise that instilling false hope was probably against the patient's best interests. Now, one of the, so I've sort of mentioned one advantage just kind of briefly, but I think I kind of wanted to tease out a couple of other advantages and then I'll finish. I guess for me, I don't know, maybe this is more to do with the book project, and I don't know how much it's going to sound like an advantage to you, but to me, one of the advantages of appealing to a virtuous doctor rather than a reasonable person or reasonable doctor is that it seems to set a more enduring normative standard for blameworthiness and moral negligence than just appealing only to what a reasonable doctor would avoid and foresee. Just to cut a bit of a long story short here, it might be that if someone pulled up one of those 1847 American doctors instilling false hope in dying patients and said, oh, hang on a minute, I don't know if you should be doing this. I've got some ethical concerns about it, despite what your professional association says. It might be that someone might try and defend that doctor and say, oh, well, kind of a reasonable doctor would instill hope even when it's false. It's a bit up at that time, maybe a little bit up for grabs what's best for patients, and then there's the AMA telling you what to do as well. So I better take this a bit more slowly, because there's a kind of key point in this, which I think is probably a better advantage than the one I mentioned before. So some might argue Dr. A is not blameworthy for instilling false hope in a dying patient, because a reasonable doctor at that time and cultural context wouldn't have even foreseen that was against their patient's best interests, so therefore wouldn't have refrained from doing so. But the worry I have about that approach or that response is that I don't think we should be relativising the normative standard to agents' historical and cultural context to that extent, so to speak. It seems problematic, because I think it's important to have a more enduring normative standard by which to judge the blameworthiness of individual doctors. And for what it's worth, I mean, this whole debate about cultural relativism, you can do the same thing when it comes to codes of ethics, professional ethics. We think it's moral progress that the AMA doesn't tell doctors to do that anymore. In fact, only 8 years later, they changed that, took that out for reasons I can go into if you want. And so I think this is I suppose the key, or a key advantage, I'm hoping, of this approach, is that if we have a standard of moral virtue that goes beyond mere reasonableness, in the way that's often been interpreted by courts, by legal theorists, and to some extent by philosophers, I think it better reflects how doctors, including Dr. A, can plausibly be expected to reflect on how certain medical practices that are pervasive and may be recommended by their associations might nonetheless not serve the proper goals of medicine very well. Kind of, in other words, I think it's reasonable to expect of a virtuous doctor, or plausible to expect of a virtuous doctor, that they keep an eye on the profession and keep an eye on, I wouldn't call it the mission. It's a bit of an Americanism, I think, the mission of medicine, but it's kind of like what I would call it the proper goals of medicine, and when the profession's going astray. Now, there's also sort of culpability from the profession, but I'll skip that. And I've got this other point, which might be of particular interest, because and I've got one last slide after this. This is sort of connected with, well, hang on, professional associations and organisations, they get some of the blame too, don't they? If they're sort of promulgating this stuff, and they say if they were to do that now. But I'm thinking about organisational responsibility and obligations. What if it actually turned out, there's a bit of an interesting puzzle here, what if it turned out that a no blame culture is more virtue conducive than a culture of naming and shaming, when things go wrong? Should organisations then seek to develop a no blame culture? And it's like, well, yeah, maybe. And then you might think this account that I'm providing is not of much use in those cases. However, I think a different response, maybe one that I'd kind of go with more to that worry, is I think we can, and I think often these days in philosophy people do, distinguish between the justifiability of a judgment that someone is blameworthy, and then the justifiability of what's an appropriate response to that. Censuring, I call them blaming responses, getting angry with them, or you should be ashamed of yourself, or whatever. So it might be that, yeah, maybe a no blame culture could mean no blaming responses, at least certain kinds, but it needn't necessarily mean that we shouldn't be looking to see who's blameworthy at all. But then there's another discussion about, well, what does blameworthy mean if no blaming responses are appropriate? But that's kind of an interesting issue in itself. But this is the further demandingness objection, which is, and this is kind of my last point, which is basically the comment I made before about, I think a virtuous doctor would keep an eye on the profession and sort of help the public understand when it's going astray, even maybe not worldwide, but maybe like in Australia, or maybe in a smaller jurisdiction. That might seem incredibly demanding. And I guess the relevance of this to the earlier case is that I think comes a time when doctors, even in 1847 or 1850, maybe in the US, should be sort of looking at whether or not instilling hope, even when false, in dying patients actually is in their best interest. And if this is like a pervasive practice in their profession, not just in their code of ethics, then let's do something about it, or let's kind of alert the community to this, because I think it's part of, to put it differently, the social remit of doctors, of medicine, to help the public see when it is going astray from its proper goals, when its practices are not actually serving those goals well. And I think it's not unreasonable or not implausible to evaluate the foresight a virtuous doctor would have, not only according to what's kind of often done at the time, but also in terms of what a virtuous doctor would be doing, and basically play their part, at least, in helping the profession to stay on course, which doesn't mean continue the sort of questionable practices, but rather stay on course of serving the proper goals of medicine. So that's this is my response to the objection. I did say I have one last slide. Maybe I'll just say it quickly and then I'll stop. So I think this is the kind of demandingness. Is it too demanding to expect individual doctors to keep an eye on how the profession's going? It's so, I'm talking about normal, not COVID normal, but sort of normal circumstances rather than public health emergencies. But you might extend it to those, like COVID. I think doctors need to bear in mind the extent to which the public is relying on them to be the sort of eyes and ears of the community about when the sort of even fairly pervasive medical practices aren't serving, patients' health well. So I think that almost like intermediary role that doctors play, I think, is really important. And even though it might not then come down to doctors to be able to do much about it, it's at the very least incumbent on individual doctors to alert the community when this sort of thing's going on. So that was my last slide, other than my references. So I'll leave it there, and yeah, keen to hear any of your thoughts you might have on.
Thank you so much, Justin. So how about we raise the hand for the questions, and I'll just make a note, and then for people who are on Zoom too. So let me.
You can take the slides off if you want.
Wait. So, okay. Gallery views. Okay, perfect. Great. So, Hoji, please.
Oh, I think the case is.
I'll go back to on people on Zoom too. Yeah,
I need to comment.
I think.
Yeah.
So I have two questions. I ask one now, and if there's time, and you allow me, I ask the second one. So, yeah, the first question is about, so one assumption here is that blameworthiness is a moral category that is a scale, that you can be more or less blameworthy. Now, I was wondering, is that, so what's your thought on the view that actual blameworthiness is not scalar? It's you are either blameworthy or not. And I think, and I'm asking that question because I think, so I'm working a bit on the no blame culture as well in the context of long-term care facilities. And my impression is that they have that dichotomous view of blameworthiness, not this scalar one that you see in a lot of philosophical literature. And I was wondering, what would be your answer to the question of why should we think of blameworthiness as a scalar moral category? Oh, concept. Thank you.
Interesting one. Yeah, I can see what you mean, because no blame culture, I suppose I'd taken it as like not any amount of blame whatsoever, be it a little amount or a large amount, to be crude about it. But yeah, but I can see often in those debates, it's just sort of like binary. I suppose in thinking of it in a more scalar way, I'm thinking that's the way that the general public use it. Maybe that people don't often use the word blameworthy, but blame, they think of amounts or degrees of it, of blame. And so to me, it's more the kind of, sorry, this is just putting it back to you. It's like, why should in the context you're talking about, why should we suddenly start thinking about it as this, as non-scalar, because maybe it suits particular pragmatic purposes there, but I'm thinking that more broadly in the community, it is scalar. It's understood to be scalar, I suppose.
All right, we'll come back. Do you have follow-up? We'll come back after Kate.
Thank you. And thanks for the talk, Justin. Sorry again that I couldn't be there today. My question is about your two doctors and the kind of intuition that you're sort of wanting to draw out of that. Because I was sort of thinking that it seemed to me like Dr. B was actually worse than Dr. A, as in like more blameworthy potentially, because I could see that Dr. A, both of them seemed to lack practical wisdom. Dr. A was just perhaps really mistaken about what it meant to serve the patient's best interests. But having decided that the doctor did know what the patient's best interests were, was sort of wholeheartedly like, it's my role to promote the patient's best interests. So was in other ways kind of aligning with their role, whereas Dr. B seems to lack practical wisdom in the sense of, as you said, failing to kind of figure out what proper goals they should be pursuing in the first place, but then was motivated by not wanting to get in trouble rather than being motivated to achieve the patient's best interest in the first place. So Dr. B actually seemed more culpable to me in the example than Dr. A. And I wondered what you thought about that.
Yeah, it's an interesting one, Kate. Yeah, I can see those reasons for thinking of Dr. A as more culpable than Dr. B. I don't know how wedded I am to thinking of Dr. B. It's Dr. A is, sorry, more culpable than Dr. B. And you were saying Dr. B might be more culpable than Dr. A. Dr. B is the one, just to remind everyone, that's the one who is concerned about the AMA judging them and saying, hey, you didn't instill hope in the dying patient. So Dr. B thought, well, I better do it because I don't want to I feel like that's some duress from the AMA. Whereas Dr. A was just sort of lacked insight, really, I suppose. into what was best for the patient. And yeah, I'm thinking it's a worse failing than sort of caving in to perceive pressure from the Pressure Association. But I can see why it seems like Dr. B is like weak-willed, and I suppose, you know, Dr. A, that's a pretty significant failure of insight. But I guess at the time, maybe it was pretty hard it might have been pretty hard for Dr. A or any doctor to have a sense as to maybe this is not really good for patients, maybe secular patients or something. So yeah, Kate, that's a good point. I don't know if it really matters that much. All I was trying to do with a comparison like that is sort of try to motivate a difference in blameworthiness, which an account might be able to capture. And if it turns out B is worse than A or more blameworthy, then yeah, so be it. I just would have to swap around where I put the examples into the argument, perhaps. I don't know if that's a satisfactory response.
Yeah, I think it would be probably fine for your purposes either way. But it was what you were just saying, making me I mean, it links to a question that I have more generally about practical wisdom, because practical wisdom, I mean, I guess it seems like actually becoming practically wise is very, very difficult. Like maybe very few people will do it or something like that. But I often wonder where or if there's a place for kind of like innocent mistakes within virtue ethics where despite your best efforts and a pile of experience and, you know, other relevant things, you make an error. You mistake what you should be doing, and whether or not that would make a difference here. Thinking
Yeah,
about,
I think I think you're right. I suppose the extreme example is, you know, Kant with, you know, we've never seen true virtue in the world, or it doesn't exist. And yeah, certainly I wouldn't want to pitch the level that high. So I think it's got to be room for innocent mistakes. I'm kind of thinking at the time, and maybe this was too implicit in the talk, that, you know, and it's based on a few things, a little bit of evidence, maybe not enough, but that even in 1847, some doctors should have been in a position to realise that this is not good for patients to instill false hope. But yeah, there was a lot going on at the time, which happy to chat about. We'll actually be quite keen to chat about when we have the time. Yeah.
Heidi, I'll just get back to you. I'll just take one question from Laura here.
Thank you so much. So I was actually having the same reaction as Kate, and I thought that but I thought I would argue that none of them were blameworthy. The first was in the grip of an ideology. The second might be genuine concern with the cause, and then you need to tell us more about the cause, because if it's going to have all sorts of detrimental effects in their career, then I don't think it's blameworthy to avoid incurring those costs, especially if they're good doctors and they can do all sorts of good things in the community, etc. So we just need more details about that case. That leads me to my question, which is, why not stick with the reasonable person for blameworthiness and go with the standard account, but then appeal to praise when it comes to the virtuous person, right? So I think the virtuous person in certain contexts certainly deserves praise, but given how much disagreement there is about even, you know, when it comes to specifying the virtues, it seems safer to just make sense of some of the agents you refer to as being more or less praiseworthy. Because, you know, even if we go back to the SARS case that you discussed in passing, people would disagree about whether that was virtuous or not, right? Like, how much courage is praiseworthy? At what point does courage become recklessness, right? So there's a lot of disagreement in society, and I think reasonable disagreement about the kind of contours of virtues. In light of that, why not just, you know, use it as a kind of as a plus, if you like, and then go for praise rather than blame agents when they fail to hit that high threshold, and then focus on blameworthiness for kind of have a kind of lower bar that we are all on board with, given that then that has effect. It can inform our legal systems and codes of conduct, etc.
Well, I've got a lot to say about that in response, and I'll try and keep it brief, and maybe we can chat about it later if we get a chance.
Yeah,
But
I'll stay for coffee afterwards.
oh, good.
Don't-
Yeah. Oh, good. Well, just a couple of quick thoughts on it. I mean, I was really keen to try to illustrate the role of foresight and foreseeability here, and I thought you could still bring that into an account of the grounds for praise and praiseworthiness, I suppose. But I'm thinking there's already a sort of ready-made structure when it comes to things like negligence and medical negligence about foreseeability and what it is, or how to sort of indicate the scope of that. Also, I wouldn't actually talk about praise and praiseworthiness. I'd talk about credit and creditworthiness, because I think praiseworthiness, you can be praiseworthy for something you don't have much control over. And if I was trying to reflect a symmetry between blame and something positive, I'd pick credit for what that might not be all that important for what I'm trying to do here, but yeah, but keen to chat more about it, because I've got this background idea, and maybe I could have brought this out more, that in 1855, like I said, they dropped that part of the Code of Ethics, but there was this huge conference with the AMA, and they realized that it's not just that, but they developed a secular code of medical ethics after this conference, and they thought this was like a reflection of a kind of like a more religious type, the good doctor has to instill sort of hope in the afterlife kind of thing. So yeah, so I'm kind of thinking, hey, it was only 8 years. Maybe some of the doctors in 1847 were kind of had wised up that this is maybe not such a good thing to do. But yeah, let's chat a bit more later.
Great, we have more questions. Heidi, nice to see you, by the way.
Hi, Sibria. Thanks a lot, Justin. That was a great talk. I just want to ask you to reflect on a different kind of case, which I think is very common today in medical practice. So it's a simple case where we can establish that there's no hope, so giving hope would be giving false hope. But in the practice of treating, for instance, cancer, I have especially cancer treatment in mind, whether there's hope is exactly the question, and the treating doctor, aware of the maybe even doing research on the developing cancer medication, is constantly having to do with that question: is there hope? What should I tell the patient? And is also concerned of the fact that whatever he or she tells the patient may actually influence the outcome. Patient not having hope possibly will fare worse than a patient that remains hopeful. New medication doesn't exist now. It doesn't look so good, but we are doing research, and it looks like there might be this other thing available next year, etc. So just like you to reflect, how does your account kind of fare with those kind of cases? It seems to me that in these kind of cases, it's crucially important for the doctor to practice practical wisdom in the kind of Aristotelian sense, to keep constantly making kind of situation and case sensitive judgments, and the doctor may fare better or worse, might do well now, next month the judgment went a little bit off. But it seems to me that when we are talking about blameworthiness, also that's my intuition, it sounds like then we are entering a kind of either or game. Now, at some point, often it is the case that there kind of starts looking like there is actually probably no hope anymore. The patient's situation is so bad that probably there won't be time to wait for the next medication. Do we enter at some point a kind of cutting point when kind of issues of blameworthiness kick in, or is issues of blameworthiness somehow relevant at the whole goal, which might be many years these days?
Yeah, I've actually been writing a fair bit on hope as part of a DP project with Steve Clark, and so I've been thinking a lot more about that kind of ethics of instilling hope in these contexts, not necessarily from the perspective of virtue ethics, but I guess one of the lessons I've learned from looking at that in more detail is that there's so many different kinds of hopes that we can talk about at end of life, and so obviously the AMA didn't, but I think in medical practice, it's important that we're talking about, I mentioned before, hope of survival, hope of a good death, whatever that might mean, hope for one's soul if one believes in such a thing. And so to go back to some of the examples that you were using, I'd probably want to, and thinking about, okay, what is false hope? Is it knowingly giving false hope? I think I mean, so one perspective is to say, just give the patients the facts and let their hopes fall as they may, kind of thing. I don't think, one might think that's, hey, that's a lesson of an ethical doctor in bioethics, how to be an ethical doctor. But I think it is okay to support and maybe nurture hope in dying patients. But it's really important what that hope is for. And like you said, it's really important that it be informed by at least what evidence there is to have hope like that. There's heaps more to say about hope, by the way. I'd love to chat with you about it some more. If we have a chance. Yeah.
Diego.
Yeah.
Thanks, Justin. So I'm reflecting on Kate and Luada's comments. So it seems like there can be disagreement about what the virtuous doctor should be responsible for in terms of culpability and foreseeability. So this is like that debate. That doesn't actually get to whether the distinction between virtue and reasonableness still stands, right? So you can have reasonable debate, we have debate about what is virtue, but the structures still stand. What I'm wondering is whether, because it's a matter of degree, this idea of responsibility, whether there are instances in which the standard of virtue, so the virtue responsibility versus reasonableness, actually begin to collapse. So independent, and I'm wondering whether that is in part due to sort of just what can be known in uncertainty. So I'm wondering what the role of uncertainty plays in actually thinking through virtue and reasonableness. So the pandemic is a really great example. It's kind of cheating because you mentioned that you were looking at kind of the more simple cases, fair enough. But during moments of uncertainty, and obviously uncertainty is sort of pervasive in medicine, what that actually kind of looks like and the influence that has on the ability to be culpable in the foreseeability aspects would seem to be impinged on uncertainty or uncertainty. So I'm wondering whether there's just instances in practice where the standards actually will look the same or be the same, or whether there's still something that I'm kind of missing such that it will continue to be separated even during moments of uncertainty.
That's a fascinating question and issue. Yeah, and I think pandemics is a good way, a good context in which to raise that. And yeah, I suppose I'm not kind of wedded to there always being a separation between what a reasonable doctor would foresee and what a virtuous doctor would foresee. In other words, that in some circumstances, a virtuous doctor would, of uncertainty, like in the early days of the COVID pandemic, maybe that standard would coincide in a situation where there's very little information about what would serve the role virtue well, kind of thing, and especially public health context and public health virtues too. But I think in a lot of other situations there can be that separation, and I don't know. I mean, so the type of examples I was using is one where the profession's just going on with just sort of continuing with some standard that is sort of pervasively negligent, almost, you could say, and yet they're just sticking to their guns. I mean, you could think of things like voluntary assisted dying as a different example, but where individual practitioners can see, no, there's not necessarily a conflict here between the goals of medicine and helping a patient die in certain circumstances. But yeah, I think it would be really interesting this would be a great research project from my point of view, would be to look at sort of the virtuous doctor in circumstances of uncertainty, pandemics or otherwise, because there's not a lot written on that. And yeah, maybe a standard that's set very high would seem particularly sort of over-demanding in that context, whereas in other contexts about, hey, keep an eye on how the profession's going, maybe it seems, if you like, defensible. Yeah.
Yeah, so Sarah and then Arthur. So let's take Sarah's question first. Yes, Sarah.
Hi, Justin. Great to hear from you.
Hi, Sarah.
My question piggybacks off Kate's question earlier. I probably had more concern with Dr. B than Dr. A as well. And it makes me sort of wonder, so your case was sort of set around the virtue of medical beneficence, as I understood it, but I guess you could say that other virtues may apply in that context as well. For example, courage, and maybe you could argue that Dr. B, for example, had a lack of courage in if you look at it through the lens of courage. So I guess in a virtue ethics approach, how would you deal with picking which is the appropriate virtue to apply in any given context, given arguably there could be many and pluralistic, I guess, ways to go about that? Thanks.
Yeah, interesting one, Sarah. I suppose I'm thinking of the kind of primary virtue or the central virtue in those two cases, Dr. A and Dr. B, as being like medical beneficence, is the one directly concerned with the goals of medicine, and courage is, medical courage is also, I think, a virtue, but it's less central to the role of doctors, but obviously comes to the fore in pandemics. And I don't know, Sarah, maybe it comes to the fore every day for all I know. Like in your work, you could probably tell me more about that. But so, yeah, but I guess I was trying to focus on the one. And I think it's difficult sometimes to know which is the appropriate one. And I agree, Dr. B showed a lack of courage. So it might be in the mix that you get of they exhibit one virtue but fail in regard to another, that one is overall less virtuous than the other. One doctor is overall less virtuous than the other. And you could maybe go either way with it. So yeah, I probably should say something more about that to be a bit more true to life and maybe true to virtue ethics as well with those two examples. So yeah, thanks for that.
Quick. Sort of builds a bit on Diego's question. Sorry to ask you about a different example from one you asked that you presented, but I wondered whether you maybe thought of whistleblowing. The reason why I was thinking of whistleblowing is because there you've got a virtue that is dictated by the professional body that then also will castigate the whistleblower if they whistleblow. So you've got a contradiction between what is being said is the virtue and the response to the enactment of that virtue. And so then I wonder whether there might be something there for actually saying that the reasonable response is to go with what the authority will support implicitly and explicitly, whereas the virtuous response is to go with what the authority says explicitly, but actually denies the professional body's implicit. And that then kind of sort of gets you out of maybe some of the traps of trying to work out what is on an absolute level the virtue, and gets to a kind of internal contradiction in what is presented as virtues within the same body.
Wow, that's a great question too, and just maybe to give a quick response. So that's interesting to me, case of whistleblowing, because it's got professional virtues and personal virtues sort of clashing, perhaps. And so I guess I would say, to cut a long story short, I would say that even though the professionally virtuous thing for a doctor to do when it comes to being a whistleblower might be to even do it at incredible personal cost, you might think, all things considered, as a virtuous person and virtuous doctor, that there are kind of limits to that, and that you shouldn't do it, even though overall shouldn't do it, even though a virtuous doctor maybe would go so far as even, I don't know about sacrificing their life. I don't know if even Aristotle would say that, but yeah, I think the sort of, the limits on that would be different depending on whether we're talking about personal virtue or professional virtue. So that's a great one that I should issue that I should think about for more.
I have questions about intuition and risk-taking behavior and how that connects to the blameworthiness, but we'll continue this conversation over lunch. And thank you so much for everyone here, and then for people online, and we'll see you soon. Thank you so much, Justin.
Oh, thanks. Yeah. Yeah, thanks everyone. Appreciate your questions. It always makes me nervous.